All right, good morning and welcome everyone. So it is my pleasure to introduce both Dr. Jeffrey Probstfield and Dr. Kelley Branch to speak this morning. Starting first with Dr. Probstfield, he is a UW Professor of Medicine in the Division of Cardiology, as well as a UW Adjunct Professor of Epidemiology in the School of Public Health. Dr. Probstfield earned his MD at the University of Washington School of Medicine, went on to complete his internal medicine training at the University of Minnesota, followed by fellowship training in clinical pharmacology, also at the University of Minnesota. In 1995, Dr. Probstfield founded the Clinical Trials Service Unit in the Division of Cardiology and has served as the director for over 20 years. The focus of activities in this unit includes identifying and supporting clinical centers for large multi-center clinical trials on both the national and international level. Dr. Probstfield's contribution to medical literature is immense, with over 200 published peer-reviewed journal articles, as well as multiple textbook chapters, editorials, and letters. He is here today to discuss the COMPASS study and his role as the U.S. co-coordinator for the study. Our second speaker this morning is Dr. Kelley Branch. Dr. Branch is a board-certified cardiologist, as well as a UW Associate Professor of Medicine in the Division of Cardiology. Dr. Branch earned his MD at Jefferson Medical College, went on to complete his internal medicine training at the University of Michigan, followed by fellowship training in cardiology here at the University of Washington. Dr. Branch serves as the Director of Cardiovascular Clinical Trials here at the UW, as well as the Associate Director of the Clinical Trials Service Unit. He is one of the founding members of the Society of Cardiovascular CT and serves on the Board of Directors for this society. His clinical research is focused in advanced cardiac imaging with over 60 peer-reviewed journal articles, as well as multiple textbook chapters and editorials. He is here today to discuss the COMPASS study and his role as the U.S. co-coordinator for the study. Please join me in welcoming Dr. Jeffrey Probstfield and Dr. Kelley Branch as they present combined antiplatelets and anticoagulants for atherosclerosis, insights from the COMPASS study.
So if my numbers are correct, I believe this is the 14th time that I've given medicine grand rounds since I've been here for over 20 years. And if you don't like what I have to say, speak to the organizing committee. Oh, my glasses.
This is what the associate director does.
Right.
Okay.
So it is our pleasure to present the results of this trial and extended analysis that have gone on subsequently. You can see our disclaimers. Well known is the fact that cardiovascular disease affects about 4% of the world population. And this is about 300 million events per year. Aspirin, single most widely used preventive treatment, but it gives only 19% long-term relative risk reduction. And I'm sure you saw the results of the recently published aspirin trial in older individuals in the New England Journal, which suggests that there may be very little, if any, protection in that group at all. Warfarin with or without aspirin is more effective than aspirin to reduce CVD events, but there is increased bleeding. Rivaroxaban is safer than warfarin and reduces mortality in patients with recent acute coronary syndromes. So this is a chart showing you the effect of secondary prevention in people who have already had heart disease. And you can see on the endpoint of MACE, a complex endpoint, mortality, stroke, and MI on the left axis. And you can see the various treatment modalities, lipid lowering, blood pressure, ACE inhibitor, looking after the results from the whole trial, and aspirin in the various boxes. I want to remind you, if you remember the InterHeart study, which we presented to this group several years ago, there is a multiplicative effect of each one of these things. So these are not additive. The results of therapy are multiplicative. Possible alternatives of aspirin have been explored in WARIS, CAPRI, CHARISMA, Pegasus and a second arm of Pegasus, and you can see the various treatment modalities that were used in those trials. And you can see there are a variety of reductions in events, more or less in the various endpoints looked at, but you can see for all of them there basically is an increase in the bleeding that occurs. So there have been some meta-analytical studies done, and for warfarin in the first comparison, you can see the reduction is about 42%. For myocardial infarction, about 21%, and for stroke, about 12%. Now, this is a very interesting mechanistic slide. And the thing I want to draw your attention to is the big red flashing thing down in the middle close to the vessel wall. Inflammation is increasingly identified as one of the very key mechanistic issues that occurs in the development of atherosclerosis. It is thought that this occurs through the exhibition of various actions from various chemokines and cytokines. And you can see how the clotting system off to the left side of the slide interact with inflammation. Now, aspirin, you can see where that acts, and you can see where warfarin acts. And warfarin obviously interacts at multiple sites. So the fact that you use the factor 10A inhibitor that we used in COMPASS gives a much more targeted therapy. So ATLAS was a pre-runner to us, trial done in acute coronary syndromes, 15,500 patients who had either unstable angina, NSTEMI, or STEMI, and they were looking for roughly 1,000 events. And you can see the inclusion criteria over to the left of the slide, and the treatment diagram shows that you were comparing rivaroxaban 2.5 milligrams a day versus rivaroxaban 5 milligrams a day versus aspirin 75 to 100 milligrams a day. 93% were on dual antiplatelet therapy actually before they started, and the median follow-up for this group was 13.1 months. So this is the Kaplan-Meier plot. For purposes of this study, they combined the two arms of rivaroxaban and put them together. And you can see when that's done, there's a 16% risk reduction. If you'll just ignore the MITT, in the view of most trialists, the modified intention to treat analysis is worthless. Then you can see for the intention to treat, and if you're into number needed to treat, you can see what that is. Now, our biostatistical colleagues at this institution basically brought this down at the FDA hearings. I had a very interesting discussion with Tom Fleming, and Tom and Professor Emerson were at the FDA meeting and said, you really don't have only a few percent loss to follow-up, you have 12% loss to follow-up. And they said, this is not the way we do trials. You cannot exclude a null result here. So it went down in flames. But if you do look at the single intervention of 2.5 milligrams a day, you can see on the outcome of CV death, MI stroke, there is a 16% reduction. Second panel, there's a 34% reduction in cardiovascular death. And for all death, there's a 32% reduction. And if you're into number needed to treat, those are along the bottom of each of the panels. So we come to the COMPASS trial. In this trial, we sought to determine if people with stable CV disease would be affected by rivaroxaban 2.5 milligrams twice a day plus aspirin, or RIVAROXABAN 5 milligrams twice daily for the outcome of CVD death, stroke, or MI, compared, the comparison arm was simply 100 milligrams of aspirin daily. Now, what you don't see in the paper, and I'm sure that by now many of you have read this paper in the New England Journal, it doesn't tell you very much about pantoprazole. We actually did a factorial design looking at pantoprazole in about 18,000 patients, looking to see if we could actually reduce the number of GI bleeds for those who were on active therapy. That trial has been completed, but if I told you the results, I'd have to use an Uzi at the door and not let you out. So the company's inclusion-exclusion criteria are reviewed here. Basically a significant history of or clinical demonstration of cardiovascular disease. You didn't have to have that if you were 65 years old, and you had to have 2 of the risk factors as listed at the lower left. The exclusion criteria basically had to do whether or not you had perhaps an active bleeding diathesis or one in the past, if you had had a recent stroke, or if you had heart failure. There are a few others there. So this is the intervention diagram. RIVAROXABAN 2.5 milligrams plus aspirin 100 versus 5 milligrams twice daily of RIVAROXABAN versus aspirin. And we were looking for 2,200 events, expected to follow them for 3 to 4 years. And pantoprazole wasn't started until October of 2018. The primary outcome measure was a MACE outcome, CVD death, stroke, or MI, and you can see what the secondary outcomes are there. The only difference between 1 and 2 is 1 is CHD death, the lower one is for CV death. IS stands for ischemic stroke, MI, or acute limb ischemia. So the primary safety outcomes had to do with looking after bleeding, and you can see the various definitions there in the top part of the left panel. What I want to note to you is that if you're familiar with either Gusto or other trials that have looked after these kinds of interventions, the requirements for counting a bleeding diathesis in this trial were actually more strict than they were for any of these other trials. Now, we also do a calculation for net clinical benefit, and my esteemed colleague is going to take you through that when he gives his part of the talk. On February 6th of last year, the DSMC recommended discontinuation of the RIVAROXABAN aspirin arms for clear evidence of efficacy. When the trial was stopped, the Z-value for R plus A was minus 4.59, with many zeros before the first significant factor. For RIVAROXABAN by itself, that is the 5 milligrams twice daily, you also had a significant Z-value with fewer zeros in front of the first significant number. Now, the miraculous thing was, and truly for those people who ever done trials, we closed out 23,000 patients in 3 months. And if you're not familiar with that, I'll just tell you, that is a bloody heroic effort. The mean follow-up for the people in the trial was 23 months. This is the consort diagram basically showing you the progression. We had randomized 27,402, and you can see there were 7 duplicate randomizations. I'm not quite sure, never any very good explanation of why those occurred, but they did. So you have roughly 9,100 patients in each one of the 3 arms. And you can see across the bottom, there were 20, 19, and 24 participants lost to follow-up. So you have a vital status of 99.8%, mean follow-up 23 months. So this was not going to suffer the same fate at the FDA that Atlas did. So the baseline characteristics, this is a very simple chart to look at. I'll just tell you that all three arms are the same. So if you just look at the first column, you can see on the characteristic of age, average 68, 22% female, average blood pressure 136/77, cholesterol 4.2 millimoles, 91% of the participants had coronary artery disease, 27% had PAD, and 38% had diabetes. For the baseline characteristics of secondary prevention therapy, again, all the columns are basically the same. So let's just look at the first one to make things simple. 90% of the people were on lipid lowering. 71% were on either an ACE or an ARB. 26% were on a calcium channel blocker. 30% were on a diuretic. 70% were on a beta blocker. 5.8% were on an NSAID. And at study beginning, 36% were on a PPI, and those people were not eligible for randomization in the factorial part of the study. So the primary outcome measure, this is very interesting because the primary outcome showed that there was a 24% reduction in risk for the rivaroxaban aspirin arm combined with 3 zeros, 1 for the p-value. On the way to the farm, that is between closeout at the end, when the trial was stopped, and the end of closeout, all of a sudden the rivaroxaban 5 milligrams versus aspirin actually reduced in its difference, and there was only a 10% reduction risk with a p-value of 0.12. So here is the Kaplan-Meier plot. You can see there's very nice separation in the three arms of the study, 24% reduction in risk. And again, if you're interested in number needed to treat, it's 77. So the components of the primary outcome, you can see CVD death reduced by 22%, stroke by 42%, and MI by only 14%. Interestingly enough, that particular analysis did not show statistical significance. And the continuing interesting thing to us, as we continue with the analysis, that still has not become significant. So just an interesting, probably by chance, but you never just say it is by chance, but probably so. Okay, so secondary outcomes, you can see the complex secondary outcomes. The first two rows are highly statistically significant. Mortality is reduced by 18%. That's total mortality with a p-value of 0.01. Now, I have to give credit to my esteemed colleague here. This is his slide. He got tired of hearing me preach over and over and over again that you need to be careful about subgroups. I have a lecture that I've given probably close to 75 times called the hazardous effects in trials of subgroups in cardiovascular, in the analysis of cardiovascular events. So what he shows you here is one subgroup saying to the other, sorry, we just can't trust you. So the way you look at subgroups and tell whether or not a subgroup may be significant is the point estimates of a particular subgroup must be different than the estimate for the overall treatment effect. And I'll show you that in just a moment. Not only that, but almost always the 95% confidence intervals must not overlap with those for the primary outcome. So I know that this is impossible to read, but you don't have to read it. What you need to look is the dots and the bars in along the estimate of treatment effect. And you can see they're all to the left side. You can see that I hope you can read that the overall estimate for the whole trial is at the very top. And what you can see is that if you compare any of those to the overall treatment effect, there's nothing that reaches statistical significance. Now, a common error is that people will take subcategories of the various reservoirs. For instance, for age, which is the top reservoir, you can see age is divided into 3. Well, you can't compare those people above 75 even with those less than 65. That is an erroneous comparison. What you do is you take either of those bars and compare them to the effect and the bars in the overall treatment effect. That is the proper comparison. So the reservoirs looked at in this slide are age, sex, geographical region, race, body weight, estimated GFR, baseline tobacco use, baseline diabetes, history of hypertension, baseline dyslipidemia, coronary artery disease, and peripheral vascular disease. On none of those outcomes do you have a significant subgroup effect. So we can say it's consistent benefit across all subgroups, and a formal statistical test for interaction does not show any interaction. To my esteemed colleague.
So thank you, Jeff. So I have the pleasure of finishing up. So I'm going to be, I'll be batting cleanup here. So as we move forward, we are dealing with antithrombotics, right? And there's no free lunch. And so in this case, as we're dealing with antithrombotics, we do see benefit. But the next question is, that's great. What's the downside? And so we looked at major bleeding. Now remember, this was a modification of a particular, what's called the International Society for Thrombosis and Hemostasis, ISTH. This was very conservative, and this was essentially not necessarily mandated, but really suggested by the FDA and other regulatory bodies, that anytime anyone came into an urgent care to say, I am having a bleeding complication, that could be GI, that could be skin, they could come in with a hematoma. Anytime they sought care, they were considered a major bleed. Now that being said, taking this conservative look, not too surprisingly, we had an increase in bleeding for both rivaroxaban and aspirin, as well as rivaroxaban alone, and you can see the numbers here. So we're going to be focusing on rivaroxaban and aspirin again because rivaroxaban alone versus aspirin did not reach statistical significance for benefit. So looking at the rivaroxaban plus aspirin versus aspirin, we see a 70% relative increase in this modified ITHS major bleed. Now that being said, I think it's also important to look at bleeds that I think are more clinically important, even though all bleeds are important, and those of fatal bleeding, intracranial hemorrhage, which I think we can all say that we are probably the most scared of, maybe somewhat irrationally so, to be honest with you. Sometimes we step over the dollar to pick up the dime. But suffice to say that the numbers were low, no statistical difference for rivaroxaban plus aspirin, and then non-fatal or other critical bleeding into the organ. Again, no statistical increase, overall numbers you can see here. So again, if we look at subgroups, this was intended so that you couldn't read it. But again, looking at all of the subgroups, you can see that there's a consistency all the way through for all of the subgroups, showing that yes, indeed, if you do this, you will achieve benefit, but at the cost of slightly increased bleeding. The net clinical benefit is one way that we can try to balance these two out, and this was a time to event. So if you had any event, either a bleeding event or a major adverse cardiovascular event, you kind of stacked those up, such that if you had if you had a reasonable decrease in major adverse cardiovascular events, but an increase in now severe bleeding, this was defined slightly differently. Severe bleeding, these are fatal bleeding or bleeding to a critical organ or intracranial hemorrhage. As you stack those up, if bleeding had actually overwhelmed the benefit, then these would have been neutral. What we see is that when you combine these together, we still had a 20% relative risk reduction for rivaroxaban aspirin versus aspirin. So the conclusion of this was that the use of this new paradigm of combining an antiplatelet and an antithrombotic reduces cardiovascular death, stroke, myocardial infarction, as well as total mortality. However, this was at the cost of this increase in this modified ITHS bleeding, but no increase in the severe bleeding of fatal intracranial or critical organ bleeding. And as such, this provided a net clinical benefit. There was no significant benefit of rivaroxaban alone. However, this seemed to be a bit of a power issue. The modeling is that if we had continued for 6 more months, we would have achieved the p-value. And that was only because we had to stop the one arm early because of efficacy. Now, that being said, we're still focusing on the rivaroxaban plus aspirin arm, and now you can see in context looking at the relative benefit for the other agents that are out there. This includes clopidogrel alone versus aspirin, the combined clopidogrel plus aspirin, the DAPT, as well as ticagrelor plus aspirin. And you can see that the relative risk reductions over to the right, a relatively modest increase in major bleeding, but and then efficacy you can see here. But I think it's important to also say that yet again, remember this is on top of patients that are well treated to begin with. In addition, these are patients with chronic coronary disease and peripheral artery disease. Now, why is that important? We know that in acute coronary syndrome or other events, those patients are at exceedingly high risk for the next year of having a major cardiovascular event. In this case, these patients were fine, but the adage is they're fine until they're not. And so you had a lot of patients, at least a reasonable number of patients, that became not within a relatively short period, median of 23 months. So as we start to add more and more medications in order to try to affect atherosclerosis from many different areas, lipid lowering, blood pressure control, ACE inhibitors, as well as aspirin, you can see that COMPASS was an incremental benefit. And so I think it's important that we take this and remember that we were really stacking on top. So we're looking at the secondary prevention therapies these patients were already on, and then reminding ourselves that the relative benefits were on top of a well-treated patient population. So this provides additional benefit rather than saying, well, you know, I'll just treat with statins. We're already doing that. We are really just finding incremental benefit. So let's delve a little bit into some of the patients, because the next question is, well, who are the patients that really derived more benefit, or who are the patients maybe we should start thinking about treating earlier? Those are always the questions that we get. Remember, there was a consistency of benefit throughout all of the subgroups, including coronary disease and peripheral vascular disease. But I think it's important to note that for peripheral arterial disease, PAD, we actually separated this out. Why? Because we know from previous studies, multiple different registries that are out there, REACH registry being one, that these patients are at the highest baseline risk for having a cardiovascular event. So we took patients with peripheral artery disease, in this case, same efficacy outcomes for the primary outcome, but then also added in something, and I think most of us vote that this is probably one of the worst acronyms around. The major adverse limb events are male. I actually have gotten the question, what about females? Kindly answer that question. It did include females. But suffice to say that this is looking at major limb events, and these are severe limb ischemia, something that actually led to some type of intervention, generally some type of percutaneous intervention, or a major amputation above the forefoot. So it couldn't just be toes, it had to be more of a major amputation. And those were male. So Sonia Anand put this together, published in Lancet, actually very, very close to the primary, when the primary outcome was reported. And you can see 7,470 patients, one of the largest peripheral arterial disease studies ever completed. And you can see that the patients were split out by symptomatic PAD, carotid disease, they could have greater than 50% carotid stenosis and get in. And we also included those patients with coronary disease and a low ankle brachial index as determined when they actually entered the study. So we actually diagnosed PAD in some of these patients, 1,422, who would otherwise not had a diagnosis of PAD. And you can see the primary outcome, very consistent benefits. However, if you look at the baseline risk, and remember this is over only a 2-year period, you can see that 6.9% of people had a major cardiovascular event. And with this, a 28% relative risk reduction, just slightly higher numerically, but really no difference between that and coronary disease. As we broke this down to myocardial infarction, stroke, or CV death, you can see the relative amounts, and I think it's notable that you have a 46% reduction in stroke relative risk in those patients. If we then looked at major adverse limb events and amputation, this is important information. Why? Because peripheral arterial disease, vascular medicine has waited almost 20 years. Almost 20 years until we've actually seen a benefit of a medication specifically within PAD to reduce these two endpoints. So for major adverse limb events, you can see the numbers here, 46% risk reduction, and then major amputation, relatively unusual. However, we had a 70% risk reduction in those. Again, this is the first time in about 20 years we've actually seen this benefit. And then actually rivaroxaban 5 milligrams did actually reach statistical nirvana down here, but again, we're focusing only on the 2.5 milligram BID plus aspirin. So Kaplan-Meier curve, again, just showing what we've seen, but again, showing what we had seen on the previous in that, yes, these patients are higher risk, but it is interesting that rivaroxaban, after about a year and a half, tended to cross over and the slope actually changed such that it was starting to near what we see with rivaroxaban aspirin. If we then looked at the overall compass effects versus those with various types of PAD, you can see that there's a real consistency of effect all the way through for the combination therapy. And so the conclusions, not too surprisingly, was that rivaroxaban 2.5 BID plus aspirin baseline was statistically superior, 31% risk reduction with a real substantial reduction in stroke. Major bleeding was increased, not too surprisingly, fairly consistent, about 60%. So when we talk about major bleeding for this combination, as we go through the subgroups, it generally ranges between 60 and 70%. So I don't know if any of you had the chance to see Dr. BRAUNWALD, right? Professor BRAUNWALD, who really is kind of the god of cardiology as we know it today at the Brigham, still came and gave grand rounds last year at the age of 88. Okay. Suffice to say that having Dr. BRAUNWALD actually do your editorial is kind of a cool thing. Okay. That being said, he said that this is really an important step forward in thrombocardiology. By the way, none of us knew that thrombocardiology was a word until Dr. BRAUNWALD said it, but we appreciate the fact that now it is a thing. But it's likely to change practice guidelines, which we also agreed with at the time. Okay, but is this where we stop? Well, no, we always have those wonderful questions that we want answered even after a major, massive trial like this of over 27,000 patients. So we'd really like to know about a head-to-head comparison between aspirin and a second antiplatelet drug, dual antiplatelet therapy, versus a low dose of a factor 10, right, such as rivaroxaban 2.5. So can you substitute, say, clopidogrel, P2Y12, or ticagrelor for or a thrombin receptor antagonist for aspirin, and then compare it to the rivaroxaban 2.5. And then taking the subgroup of patients with stable ischemic heart disease, ACS, or those with heart failure, those various combinations, and putting those two together. We think this is a great idea. So if anyone has anywhere between 50 to 100, about $200 million sitting around, we would love to do each one of these studies. In lieu of that, we may have to wait, but there will be at least some of these studies that will probably be answered within registries, but not randomized controlled trials. Now, the next thing is, I think I'm preaching to the choir here to say that randomized controlled trials are sometimes met with a little bit of hesitancy, in that when you look at this, you say, well, you know, are these really my patients? Is these the patients that I see either as a cardiologist, as a general practitioner, as a vascular medicine specialist? So have we sub-selected patients so that we really increase risk and or benefit? Right? Have we tiddlywinked to this to make it look good? Well, what we did very soon after is that we looked within the REACH registry, which is a large registry, over 45,000 patients with coronary disease and peripheral arterial disease, and said, how many of these patients actually would meet criteria for COMPASS? And of this, we had 16,875. Arthur Darmond did this. Jeff and I are co-authors on this. And the idea is that how are these patients similar in those patients that are kind of real world? And what we saw is that not only were patients not at higher risk within COMPASS, the patients were actually lower risk than those seen in a registry, suggesting that patients, yes, indeed, we did see a substantial number of patients that would meet this, that had chronic coronary disease and peripheral arterial disease. But not only that, they actually had similar or even lower risk than those patients kind of in their native habitat. So a couple other questions, and Professor Probstfield and I have spent a lot of time trying to figure out, now that we have really a new paradigm, something that a real shift in how we think about things, who do we treat, who is responsible for starting these, and then when do we start this? When is an appropriate time in order to initiate therapy to try to provide benefit for all of our patients? Well, we get a little bit of clarity from the FDA, and right now this particular combination has been approved in Europe, it's been approved in Canada, and it's been very recently approved as of a week and a half ago by the FDA here. And if we look at the product insert that was presented for indications and use, you can see down in the highlight here that Xarelto now in combination with aspirin reduces major cardiovascular events in chronic coronary disease and peripheral arterial disease. You'll notice that it doesn't say anything else, which I thought was pretty generous of the FDA, to be honest with you. Sometimes they try to replicate COMPASS, which was not easy to do. And if you compare this to what happened in Europe, the added language was that it had to be high-risk cardiovascular disease patients. In addition, if you looked at the dosage of administration, you can see down here for the reduction of major cardiovascular events, 2.5 milligrams of Xarelto with or without food in combination with aspirin. So what are some of the subgroups that really seem to benefit a little bit more, at least numerically, as far as a number needed to treat? Or do we see actually any differences within these patients? So these were some data that I presented at a late-breaking trial at the European Society of Cardiology, heart failure, and you can see that patients by heart failure status, just by having heart failure, and that is a checkbox to say that they had heart failure either currently or at some point, you can see those patients are really at much higher risk for having a cardiovascular event. That's the red that you see here in the dashed line. And you can see a substantial decrease now, in this case 32%, and an absolute risk reduction of 2.4% for a smaller number needed to treat for those patients with heart failure. So finding those patients with a history or current heart failure may actually have a lower number needed to treat, higher absolute risk reduction. And so maybe a reasonable patient to first start therapy to try to get used to using this drug. We still showed benefit within those patients without heart failure, but a little higher bar in order to achieve benefit. If we then looked more substantially, and I think more globally, at the high-risk subgroups, and this is actually confidential information, so you see confidential up here, right? You guys get it first. This is a paper that is currently in review. Knock wood, will be published within the next probably 2 to 3 months. But looking at high-risk subgroups, those patients with heart failure, with polyvascular disease, and that is with peripheral arterial disease, cerebrovascular disease, and or coronary artery disease, 1, 2 or more of those patients were really substantial high risk, and we've seen that again and again and again. Once you have disease in more than one bed, very significant increase. Peripheral arterial disease by itself, those with a decreased GFR, and those with a REACH score, which we don't have time to go into today. But suffice to say that there are high-risk groups which are more reasonable to treat just for the added absolute risk benefit and the higher risk overall. But just to remember that there was consistency throughout, and so we don't throw the baby out with the bathwater, in that many of these patients that met COMPASS criteria did benefit, at least all the patients did. But suffice to say that there may be some that benefit a little bit more initially. Now, the other question is, who is responsible for starting rivaroxaban? And here's the challenge. So if we were to say, we're going to ping people to say, who is the person that's going to start it? Well, for patients with coronary disease, over to the right-hand side, most of this is going to be deferred to cardiology. I think most of my internal medicine colleagues would say, you know, thank you, nodding, right? Yes, please, why don't you take care of that? You know, my drug, right? Okay, and that's fine. On the left-hand side, it's more interesting. What do you do about that very high-risk patient cohort of peripheral arterial disease who may or may not see a vascular medicine specialist, right? Because we don't have very many of those around, as you know. Or they'll go see their vascular surgeon, who are, curiously enough, interested in vascular surgery, by definition, right? Not as much into vascular medicine. And so if you look at those patients aren't even treated as well with things like statins and aspirins, right? So who does it fall to? Well, oftentimes peripheral arterial disease falls to the primary care, the gatekeeper. And that's one of the reasons why we present this data to you, because you're going to be coming up on the front lines for your patients with peripheral arterial disease to say, we need to make sure that you are on guideline-based medical therapy. You got to be on your aspirin. You got to be on your statin. If appropriate, you got to be on, you know, some of these other medications that we had talked about. But we should also consider the COMPASS-like regimen, the rivaroxaban plus aspirin, in those patients with peripheral arterial disease for that benefit, especially stroke, which will also influence your patient's ability to take it. Because remember, they have to be part of the conversation. Why? Because 2 times a day, they have to agree with what you just suggested, right? That's adherence. So when is the possible time? Well, just to remember, everybody, that these are chronic patients, chronic coronary disease, chronic peripheral arterial disease, and they are fine until they're not. And the reason why we have these conversations is because we don't want them to get to the not. The bad time, I talked to my patients, I said, I don't want to have this conversation with you in the ICU. That means we failed. I would like to get to you sooner. So when are some possible times? One of the logical times is once they stop some other medication. In this case, if they've had some type of event, acute coronary syndrome, peripheral arterial stent, something like that, and they stop their dual antiplatelet therapy, that's a reasonable time to switch over. Click. Now's the time to go on a medication which will move you into the chronic phase, and this is a better medication than just aspirin alone. If the patients have new symptoms or you're treating medically for something, this is a good time to say, hey, we just diagnosed you with peripheral arterial disease. Here's a medication which is going to be beneficial for you, right, to prevent some major events. And if you want to have somebody and influence them, 2 things you talk about, right? And I think everybody knows this. Number 1 is stroke. Number 2 is amputation. MI, stent me. It's fine. Cardiovascular death, I want to die in my sleep anyway. It's fine, right? But if you want to affect it, stroke and amputation, that's what people are scared of and can start the conversation towards adherence. And then anytime we have new risk factors or you've now recognized that this is really a high-risk patient, that's a reasonable time to start. So in conclusion, we've seen a new paradigm here. And COMPASS is really now steering us towards a new course for chronic coronary disease and chronic peripheral arterial disease. And in this case, this is rivaroxaban, 2.5 milligrams twice a day, plus aspirin. We see that the decreases major adverse cardiovascular events by 24%. And again, it's across the whole spectrum of disease. We have higher risk patient populations, where they have more absolute baseline risk, more absolute, and therefore higher absolute risk benefit. But again, it happens across the spectrum. Using our conservative bleeding, yes, it does cause bleeding. Some data that were not shown here within the CAD arm, which is approximately 90%, we showed that when did the patients bleed? A landmark analysis actually showed that the patients bleed the first year, and then after that, there's no significant increase in bleeding for the next 2 years. So it seems like there's kind of a stress diathesis model in that if they're going to bleed, they bleed early. We identify them. We either identified problems, right? It's like as an ulcer that we can treat. Otherwise, those patients, as they move on, they did not seem to increase over time. As such, the net clinical benefit, when we combine major adverse cardiovascular events plus bleeding, we still showed a substantial benefit towards low-dose rivaroxaban aspirin combination in these patients. But I can't stress enough that in patients with peripheral arterial disease that we are now seeing a significant benefit. This is the first time in decades that we have actually seen a benefit within these population. And so I think this is an easy sell. But who are on the front lines? That includes a lot of people in the audience here. And that's one of the reasons why we provide this. So some of the challenges that we're going to be working with, which patients to target, because this is not going to be an inexpensive drug. To be honest with you, even at this point, I don't have what the cost of the drug is going to be. Rumor is that it may be the same cost as what standard rivaroxaban is per day, rather than per pill. But I don't have. But even now, we don't have the actual cost. We do need to have robust cost analyses. There are two that are currently in production. One of which was presented at AHA, but again, we didn't really have the cost of the drug, so until we have that, it's going to be difficult. And then we additional comparisons to other contemporary treatments, and that unfortunately may fall into the registries. Potentially over time, we can do trials, but until then, we'll have to leave it to registries. So with that, I'd like to thank you for your attention. I'd like to thank, of course, Professor Probstfield, who took me out of obscurity in imaging to actually become a clinical trialist, and I've been at his right hand for the last 5 years, and I can't say enough to Jeff for his tutelage. But in addition, imagine what it takes in order to get 27,000 patients into a trial. And these are just the people on the steering committee. This doesn't even count all of the 600 sites and all of the 2,000 people that were involved just in getting patients in. But you can see, thank you to Janice Johnson, Jill Anderson, Greg Mueller, who's here in the audience today, and Deepak Bhatt from Harvard, who's part of the U.S. national leaders, all of the investigators, the trial leadership in Hamilton, you can see here, the steering committee, and of course, all of the participants, including the 60 participants here at the University of Washington. So with that, I will go ahead and end, and I would like to thank everyone for their attention, and we'll go ahead and take questions.